The organoleptic score is 0, tongue coat and tongue coat score is 1, no caries. What is the condition known as? So basically in the question what he is suggesting, am I all audible to and visible to you? Yeah. So in this question if you see whatever history he has given for the patient, it is very clear that the patient does not have any bed breath. It is just that the patient believes that the bed breath is present because his organoleptic score is also 0, and there is tongue coat and there is hardly any tongue coat. So it means this is a condition in which there is no halitosis. So in which we can easily rule out the option C and D, intraoral and extraoral halitosis. Now to differentiate between pseudohalitosis and halitophobia, so you need to see when the options has fear and some some points like this, then it becomes halitophobia. But in this, when the organoleptic score is 0 and still the patient believes that there is some bed breath that is coming, that is pseudohalitosis. So pseudohalitosis is when the person believes that the bed breath is present, but his oral hygiene is fair, organoleptic score is 0, and he has gone previous treatments for halitosis, that is pseudo halitosis. So the option for this first answer for this first question would be pseudo halitosis. Now the second question was a pictorial question in which they asked what does this cross denote. So we all can see if it is the same question that's been asked. The above area is free gingiva, then is attached gingiva, and then the cross marked line is mucogingival junction. Sorry, this is attached gingiva, and this is free gingiva, this is attached gingiva, and this is vestibular mucosa. So they have asked about this cross thing. So just below the attached gingiva there is alveolar mucosa. So there must be one option as alveolar mucosa, and the answer here would be alveolar mucosa. If this cross would have been between the free gingiva and the attached gingiva somewhere here, that would have been mucogingival junction. So the answer here should be alveolar mucosa. I don't have options here, but this should be alveolar mucosa. Okay. The next question is, how are age and periodontitis related to each other? How are age and periodontitis related to each other? So now for this you need to understand risk factor, risk determinant and risk indicator. Now if you need to know the definition of all this also, because it is very important and a lot of time it has been seen like the examiner asked the definition of this, and we have done this a lot of time in our class and other YouTube sessions that we have taken previously. So a risk factor may be environmental, a behavioral or a biological factor that increases the likelihood of the disease. Okay, so that all those factors which increases the likelihood of the disease are risk factors. Risk determinants or background characteristics are sometimes they are the risk factors which cannot be modified. They are the risk factors which cannot be modified. Okay. A risk indicator basically those factors that can be identified in cross sectional studies but not in longitudinal studies. Okay. uh, One second please. Okay, so this is risk indicator, risk predictor, or risk markers. They are associated with increased risk of the disease, but they do not cause the disease. Now, the important thing is you need to understand what are the conditions which comes under risk factor. So, risk factors: smoking, diabetes, mellitus, and other periopathogens. They come under risk factor. Risk determinants or background characteristics are age, genetic factors, gender, socioeconomic status, stress. All these comes under risk determinant. Risk indicator are HIV, AIDS, and osteoporosis. And risk markers are previous history of periodontal disease and bleeding and probing. Now, if you see the options, the first option are how are age and periodontitis related to each other. So, age is an etiological factor. Age is not related. Age is a background characteristic, and age is a risk marker. So, we know out of all these options, age is a risk determinant, also known as a background characters. So, the correct option here would be option C. So, please read all the options, and this is very important. I have seen a lot of times this question being asked. So, just go through this whenever it's very important. Risk factor, risk determinant, risk indicator, and risk predictor. Okay, now the next question was beta defensins 1 and 2 are absent in, and the options were saliva, junctional epithelium, sulcular epithelium, and connective tissue. Okay, so these were the four options. And first of all, to know this, you need to understand what are beta defensins. So beta defensins are basically some immune factors in our body that helps you to maintain, that protects the oral environment from a different bacteria, fungal infections, and viral infections. Okay, now these beta defensins 1 and 2, they are present in a lot of places in the oral cavity, but they are absent in junctional epithelium. Okay, so out of all these options, it is present in saliva, it is present in sulcular epithelium, it is present in connective tissue, but it is absent in junctional epithelium. So the answer here would be B, junctional epithelium. Okay, so the next question was, what is the minimum recommended distance between two dental implants placed in edentulous rays to ensure optimum bone health and implant success? So again, a very important question for implant and a very simple one. We have already discussed this a lot of times. So the distance between two implants should be at least 3 millimeters, and the distance between your implant and adjacent tooth should be 1.5 to 2 millimeters. Minimum should be 1.5, and if we ask ideal, it should be 2 millimeters. Okay. And on the buccal and lingual side of the palatal side, at least 1 mm of bone, and ideally 1.5 to 2 mm of bone should be present. So, what is the minimum recommended distance between two dental implants? So, he is asking the distance between two implants. So, answer here would be 3 mm. Okay, next question. What is the recommended working force applied when using a CPITN probe? So, now, again, what I can gather, I saw a lot of questions on CPITN probe. So, it's very important for us to understand the different things about CPITN probe. So CPITN probe, as we all know, is also known as a WHO probe. The weight is around 5 grams for this probe, and there are two kinds of probe. One is CPITN E and the other is CPITN C. Now the basic difference between E, that is epidemiological probe, and the clinical probe, that is C. CPITN C is basically a probe that has a 0.5 mm ball tip, and there are two markings from 3.5 to 5.5, and the second marking is from 8.5 to 11.5. As compared, in the epidemiological probe, the marking from 8.5 to 11.5 is absent. Okay, so it means we need to first see which probe he is asking for. If he has asked generally what is CPITN probe, you just need to answer according to the CPITN C. So now there are four different probes, four different options here. He has asked about what is the recommended working force? So please remember there are two types of probing forces. One is working force and second is a sensing force. A working force is when you're doing the probing. So we all know the probing force should be less than 25 grams, and the sensing force should be just to sense if there is some calculus present or not. So the sensing force would be less than the probing force. So the working force should be ideally less than 20 grams when you're using a CPITN probe. So answer here would be 1. Okay. The next question that came was that the Merkel cells are most commonly seen in. So the Merkel cells, we all know they are present in the deepest layer of the epithelium, that is stratum basale. Okay, and they are found in stratum basale. Okay, so the answer here would be B, stratum basale. And the role of Merkel cells is to help in tactile sensation or touch receptors. Okay. Next question was a patient having gingivitis with type 2 diabetes mellitus. What is the most common subgingival flora? So now we need to understand a patient with type 2 diabetes mellitus, the bacterial flora, the maximum amount of bacterial flora ideally in any kind of periodontitis is P. gingivalis, but in patients with diabetes mellitus, T. denticola and P. gingivalis is maximum prevalent. It is also seen that the prevalence of A. comitans and Fusobacterium nucleatum is also seen. But if they ask you the maximum prevalence of the most common subgingival flora, the answer here would be C, that is P. gingivalis and Treponema denticola. Okay. The next question was a patient reported with mobility with respect to mandibular posteriors, mirror-like image and bone loss. So he has given all the classical symptoms that you can see in aggressive periodontitis, and that too localized aggressive periodontitis. Because it's just mandibular anterior, it is localized, the condition that he has said, and it's a mirror-like image bone loss, that it means it is kind of a vertical bone loss that is seen, a bone loss that is seen in aggressive condition. Okay, so answer here would be A, localized aggressive periodontitis. There are a lot of options that are recalled and there are corrections. So these are recalled options that we have gathered, we have got from the students, and I can see there are some corrections in the options. Okay, and if you feel there are some different options, you can put it in the comment box and we can discuss that also. Okay, that next question that was recalled was Ordland bodies are. So Ordland bodies are basically, we all know, they are modified lysosomes that are mostly seen in stratum spinosum, and they release acid phosphatase, not alkaline phosphatase. So out of these options, option A is the best option and correct answer here, that it is modified lysosomes. Most of these questions has been discussed in the class already, and I believe the perio paper and implant paper this time was very easy, and ideally you should have been able to attempt all the questions properly. Next question was identify the true statement about chronic periodontitis. Okay, so the first, now again this question, the options must be different because let's read the options and understand if these were the recalled options, there's something wrong with this question. So now he's asking which is true about chronic periodontitis. The first option was gingival inflammation is present in chronic periodontitis. Attachment, so we all know gingival inflammation is present. So this is a correct option. Second is attachment loss in chronic periodontitis is reversible. So this is a wrong statement. We all know because there is bone loss in chronic periodontitis, and any kind of bone loss is not reversible, it is irreversible. So option B is wrong, but option C is correct. Attachment loss in chronic periodontitis is irreversible. Now it means option A and C is correct, but we have option D, that it is both A and B. So out of, if ideally this D should be option A and C, that would have been the better answer here. Okay. If I have to choose one single option, I will choose option C. Attachment loss in chronic periodontitis is irreversible if these were the options. CPI10 probe question has option force less than 30. That would again, but what were the other options? Was there any option 25 grams, 30 grams? What were the other options? That also, the answer also depends upon that. So if the option was force less than 20, force less than 30, again I will choose force less than 20 as the best answer, because there are a lot of references. I can show you one reference also in which the probing force, the working component force should not exceed 20 grams. And there are a lot of articles regarding that also that says the force should not exceed 20 grams. If the option was working component as given in the option, even if the force was 30 grams, the answer would have been 20 grams if that was the option. If 20 grams was not in the option, then you would select 30 grams or 25 grams, whichever is the minimum. Okay. Okay. Next question. Yes, then option less than 20 grams is the best answer here, not 30 grams. Okay. Okay, so this was not very okay. Next question was bruchite is seen in which area most commonly? So we all know that there are different composition of in the different composition of calculus. Bruchite is 9%, octyl calcium phosphate is 12%, magnesium white leucite is 21%, and hydroxyapatite is the maximum 58%. Your supragingival calculus is made up of hydroxyapatite and octacalcium phosphate, and your subgingival calculus is made up of hydroxyapatite and magnesium white leucite and some amount of bruchite. Bruchite is mostly seen in subgingival areas of mandibular anteriors, and in mandibular posteriors magnesium white leucite is seen. So in this question, option A, that is subgingival calculus of mandibular anterior region, is the best option and the answer here. Okay. Now again the next question was, I don't know about the options if they are correct. Out of these options what I have got, that the question was most common organism in subgingival plaque in a patient with chronic periodontitis. So we all know in subgingival plaque in chronic periodontitis, P. gingivalis is the bacteria that is present in maximum amount and is also the most lethal and most dangerous bacteria there. So out of these options, if these were the options anyhow, the answer here would be P. gingivalis. Okay, so next was an image based question. Calculate the clinical attachment loss from the illustration given below. Now to understand this first, we need to understand what is clinical attachment loss. So clinical attachment loss is basically the distance from the cemento enamel junction to the base of the pocket. Okay. So now in this question you can see the probing depth here. Probing depth is from the crest of marginal gingiva to the base of the sulcus. So that is given here is 4 mm, and he has mentioned 1 mm is the recession, means from CJ to the crest of the gingiva. So we need to just total this to get the clinical attachment loss. It's a simple straightforward question. You have done these kind of questions in the during the class also. So the answer here would be 5 mm free. Okay. Next question was, what is incorrect about universal curate? Again, a very simple and a question that's been asked a lot of time. So we know the difference between the universal and the Gracie curates. Universal curates are curates basically that has that can be used in all areas, and Gracie curates are area specific. So universal curates have both cutting edges and Gracie curates have one cutting edge. Universal curate is curved in one plane as compared to Gracie curate, and it has a blade angle of 90 degrees as compared to 60 degrees for Gracie curate. Okay, so out of these options we know an angle of 60 degrees is not correct. The angle should be 90 degrees. So it is an incorrect option and a correct answer here. Okay. And also ideally option A is also wrong. Blade is offset. Offset is 60 degrees. Maybe the question is what is the correct option of universal curate? So ideally in this both cutting edges, that is option 3. So there is something wrong within this option. If the option is incorrect, option should be incorrect, then option A 1 and 2 both are incorrect. If the question is correct, then option 3 is correct here. Okay. So maybe the recalled question is not correct. Okay, the next question that was recalled was ideal mesiodistal space required for placement of two standard implants in a mandibular anterior region. Okay, now two implants. Okay, now first of all, you need to understand mandibular anterior is the smallest tooth. The smallest size of the implant generally, for example, you take is 3.5 millimeters of diameter for mandibular anteriors, or maybe 4, but let's take it as 3.5. So 3.5 plus 3.5, two implants, that is 7 millimeters. Inter-implant distance is 3 millimeters, so 7 plus 3, 10. Okay, and at least 1.5 to 2 mm of space from the adjacent tooth. Now, 10 plus, if I take the minimum also, so it is 3. Okay, now he has asked ideal, so I will not take it as 3, I will take it as 4, because I told you minimum distance is 1.5, ideal is 2. So 3.5 plus 3.5 is 7, inter-implant distance is 3, so 7 plus 3, 10, plus 2 on the mesial side and 2 on the distal side from the adjacent tooth, so it is 14. So ideally the best answer here out of this option is 14 mm. But I would have liked if the examiner would have mentioned the diameter of that implant. So if you remember, was the diameter of the implant mentioned in the question, or the options were not very near? Was 13 mm also in the option? Can you remember this question, any one of you? But out of this, I would choose 14 mm as the best answer here. Okay. So if you can recall, just put it in the comment box. I will discuss that. Okay, one more question was recalled for CPITN probe. We have already discussed. What is this? This is a CPITN probe, ideally to be more specific, C. And the markings are from 3.5 to 5.5 and 8.5 to 11.5. So the option here would be 4. Both WHO and CPITN are same. They can be used, but here the options are being turned upon by the examiner to confuse you. So the answer here would be 4. Okay, what is this kind of suture that is shown in the following image? Now see, just see this, the movement of the needle. In this image, the needle is moving from outer of buccal, and then the needle is again moving from outer of lingual, and the knot is given. So this is classical figure of 8 suture. What is the difference from simple loop or interrupted suture? The needle goes from outer of buccal as it is going in figure of 8. But then the needle goes from inner of lingual. As compared to in figure of 8, it is going from outer of lingual. So the answer here would be A, figure of 8. Okay. The next question. Now again, in this question, I am not sure what the examiner has asked, because this question, how it was recalled, is identify the defect related to the image. So was this arrow there in the question? If this arrow was there in the question, then the answer would be different. If he has not given the arrow, if he is asking about both the defects 1 and 2, then the answer would be different. So now first of all, let's understand what it is. You know, dehiscence is when the marginal bone and the marginal bone is not intact, it is known as dehiscence. And when the marginal bone is intact and the bone over the tooth root at somewhere along the tooth root is absent, but the marginal bone is present, that is fenestration. So now what the arrow marked as fenestration, and on the left of it, on the central incisor, lower central incisor, that's a dehiscence. So it could be both A and B if he is asking about both the things. If he is asking about the marked one, it would be B. So I don't know exactly what was the option, what he has asked, but you know how to differentiate between dehiscence and fenestration, and accordingly mark this answer. Okay. If he's asking about this arrow mark thing, that is fenestration. Okay. Okay. So these were all the recalled questions that I could gather from the perio and implants. If you had any views about the options or maybe some other questions, please post it in the comment box, or you can put it in the group, WhatsApp group what we have, and we can discuss that. Okay. Thank you so much.